This conference will now be recorded.
Hello everyone. Today again we are going to talk about study designs. This is part 2. For the part 1 you can go to the YouTube channel and I hope the link is available in the group as well. So today we are going to talk about case control studies. What is the design? Why we do such studies? What are the advantages and what are the limitations? Dr. Aisha with you. So let's start the session. So, just a brief overview of the classification of designs. If you guys remember, yesterday I told you that basically we have two types of studies, the descriptive ones and the analytic ones. The descriptive studies, they will examine the distribution of a disease in a population in terms of person, place, and time. While the analytic studies, they will be testing a specific hypothesis about the relationship of a disease to a specific cause. That is one thing. This definition distinction was made by Penn. So in the descriptive, we are just doing the observational studies. And in the analytic studies, obviously, we are going to analyze something. So what do we analyze? We analyze data. So the study designs, like I said, they can be descriptive or they can be analytic. In the descriptive designs, there can be case report, case series. These can be cross-sectional studies that we are doing at a certain point of time. Just could be a single study or could be a multiple study at time. At single point or multiple points depends that what is the schedule of the study, but usually at just one point of time. Ecologic, when this is also a type of descriptive study, but in case report and the cross-sectional, we have individual level data, even in the case series. But in the ecologic studies, we have data at the level of a country, a larger population, a tribe, a continent. Okay, so this is the group level data. Regarding analytic studies, again, they can be observational studies or experimental studies. Among the observational studies, we can include case control studies, the cohorts, the cross sectional, and then in the experimental studies, we can do the randomized control trials or we can do the quasi experimental studies. These studies are just like trials, but the data is not randomized. That's why we call them quasi experimental. So, the case control studies. Why do we do them? Each type of study is going to answer a different type of question. If your study question or your uh, topic sentence is what risk factors, these are the exposures, increase or decrease the likeliness of the outcome. So this type of question can be answered best with in a case control study. So we can say that a case control study is a type of observational study in which two existing groups differing in outcome, they are identified and compared on the basis of some supposed causal attributes. So the study question again, what risk factors or exposures increase or decrease the likeliness of the outcome? So if a person has had exposure and developed disease, we define them as the cases. For the cases, you have to give a specific definition. And then for the people who were also exposed, but they are not having the disease. So we are going to compare these two groups. That what happened, why a certain number of people has developed disease and why others have not developed disease. So we will go back and we will see that what is the assessment of the exposure. Were these both groups exposed to a risk factor or only the people who have developed disease, they were exposed to a certain risk factor. So the people who have developed a certain disease, we will consider them as cases, and the people who have not developed the disease, we will keep them as controls. So, in the cases, we will like to see what they exposed, or were they not exposed? Similarly, the controls, we would want to see that they were exposed or they were not exposed. If I give you certain examples of case control studies to make my point, so we can have two examples. Is there an association of high carbohydrate intake and development of diabetes? Or is there an association between high fat consumption and colon cancer? So this type of study questions, they can be answered with the help of case control studies. So when are case control studies suitable? They are very suitable if you are assessing this type of things like exposure data is difficult or expensive to obtain. So we cannot reasonably sample everyone or test everyone in the city. So we need to save time and money. And when the underlying population is dynamic, like this is like an outbreak where the people are falling sick and they are recovering quickly. So the population is changing its features very quickly. Then constant change is hard to measure and that cannot be accurate. So you are going to assess like one episode of an epidemic, like the people who took food from a certain place, certain restaurant, they are falling sick. Okay, so you are doing it. So you are not going to collect data for like a month, a year, or some or longer periods of time. Okay, just one event has taken place. There was an outbreak of food poisoning, so you would want to see that what is the difference between the people who had risk factors who ate from that hospital, that joint food joint, or those who didn't eat from that food joint like that. Okay, or those who were exposed to the same food but still they didn't develop disease. So you would now want to have full information on an outbreak. So you can also use case control studies when the disease has long induction and latent period. So, but you would have to wait long times. So usually we are using them case control studies for the acute outbreaks. So we can also do them for the rare diseases. So to estimate the rare diseases, to study the pattern of the rare diseases. So what are the rare diseases which have a prevalence of less than 20%? So we can identify cases from the registries, surveillance, or the hospitals. And other study designs, they require big sample sizes to get big enough sample and be for the rare disease. So and then they will have a statistical power as well. We can also use case control studies when the disease etiology is unknown. What is etiology? That what has caused this disease. And when we are searching for a cause or exposure, what has caused this disease, how the persons have developed it. It can also look at the numerous exposures and levels of exposure. I will give you one example. Like a woman in early pregnancy, she didn't know because that she was pregnant because she didn't miss a period, didn't do any testing, but she has been exposed to the radiation. Why? Because she had some respiratory infection and the x-ray has been done. So depends that what sort of problem she had, what type of imaging was done on her, and what was the level of exposure. Like maybe you did an x-ray, so the amount of exposure would be like 4 rads, which is much less than the daily exposure. Then if you have multiple hypotheses and you need to associate them with the outcome, then again you can use the case control studies. So basically you are using it to see the differences between the cases and the controls. So there are certain steps if you're planning to conduct a case control study. So like the first step would be that you should select study population. Then you should be able to identify cases, like you need to define that which person is a case, what characteristics that person should have, and what do you expect to see. in time frame, in time, place, person. So all things they are going to limit it. So you will have to define the cases very clearly. Then, what are the sample controls? You should remember that the only difference between the cases and the controls will be the outcome. Maybe they had the same exposure, or maybe they were not exposed, but you are going to focus at the outcome. So you need to measure exposure, then calculate odds of exposure among the cases and controls before giving your definite opinion. So let's go into details of each of these steps. Like you need to define the study population, and which is selected from the entire population that produced the cases, like everyone who went to the same restaurant or everyone who went to the same party and ate same type of food items. So the population must be, so we must clearly define our study population to avoid misclassification bias. Efficient and accurate sources they must be used to identify the cases, and the cases they can come from the general population, from the disease registries which are maintained by the Department of Health, or from the surveillance activities, then from the hospital records, and so all of these are the sources from where we can identify the cases. There can be problems with generalizability because you are just observing a population of the people of the in the study which has been taken from the entire population. So we cannot generalize the results. What is generalizability? That can be apply the results obtained from your case control study to the larger population, like population of that city. So we cannot. This is also different from the randomized controlled trials because in the controlled trials we can apply the results to the population outside the study population, like the whole country or the whole world for that matter. And then study population, sometimes the people they can travel to another place for the treatment. So you will have to see that from where they have come and what type of risk factor they were exposed to. If selecting hospital cases, then you should use controls from a variety of hospitals in that area, just to decrease the chances of having bias. You should identify the cases, clearly define what criteria makes a case, what criteria make a case. Remember the case definition I told you from the previous slide, then clear inclusion exclusion criteria. They should lead to accurate classification, signs, symptoms, diagnostic test results, international codes for disease or the free text. Then incident versus prevalent cases, they should become we should have this information. Incident cases they are preferable to the prevalent cases. Incident cases, the new cases which have emerged. Prevalent, the pre-existing, and then new cases total in the population. But we are interested in the new cases. More prevalent cases, but risk factors they might be more attributable to survival as opposed to the development of the disease. And when we are looking at the disease etiology, then we should use new cases. What has caused this disease? And prevalent cases, they are more common. Why? Because in the prevalence, we include the older cases, the existing cases, and the new cases in a society. So the prevalence is mostly more than the incidence. We should identify controls. If the control had gotten disease, there would have been a case. So the person who is a control, most likely the person will not have disease because he's a control. Because if he will develop the disease, then he will not, and this person will not be a control. He will, this person by default would become a case. Why? Because this person has developed a certain condition. So controls must be free of outcomes. So the controls they should be anything, but they should not be having this disease of interest. Okay, they should not be having this disease. That is the basic point. Okay, so the controls, they should be representative of the study population from which the cases arose. Be it the controls should be taken from the same population from where we have selected the cases. We cannot do it like this, like we are selecting the cases from the hospital and we are taking the controls from the general population. So this cannot be the case. Okay, so they have to be matched. So controls selected independent of exposure status. Ensure comparability among the cases and controls. Cases and controls, they should have same probability of being selected. Like it should not be like this that the cases are more likely to be selected. In that case, that will be a selection bias. So, what can be the possible sources of the controls? These can be population controls like the community controls, and when cases are from a well-defined population. For example, like you can collect the cases by their zip codes, by their area codes. We can also use the voters list, driver's license, directories, etc. And the controls. Uh, and they should be like the positives should be there because easy to identify and they come from the same source population. The positives and the negatives, they are hard if recruiting lower level of interest when healthy. Recall bias can always be there, so we have to be very careful about it. Which type of bias is most commonly associated with the case control studies? The recall bias, especially if the person is healthy. Regarding the controls, what can be the controls? Can be the friends, spouses, can be the relative controls like the community controls, and they can be like less commons, and they can be from the same socioeconomic status, uh, socioeconomic groups. They can be from the same race, education, age, or the genes. And the negatives, unwilling to nominate or to be too selective, and it will lead to bias. These are the pros and cons of selecting the controls. So the sources of control, hospitalized patients, and we call them hospital controls. And the investigators, they use hospital clinic to get cases and use the same to get the controls. And they don't have outcomes of interest, and the positives would be these are the captive audiences, and they are literally easy to identify. Why? Because they were sick and they came to the hospital, so we have selected them. So they have good participation rates because they want to know that what has caused their disease, so they are very willing to share their information. And then lower cost to recruit because we are not calling any persons, we are not emailing them, calling them, or engaging someone to talk to them. So because they are in the inside hospital, so very easy to recruit. But what are the cons or the negative points about it? That this can make mistakes with this, like what is an appropriate disease for inclusion. That is one thing. Okay, then a continuous problem seen by many people would be incomplete medical records. Then recall bias, like I will tell you about a study, like it was done on the women whose children they had hypospadias at the time of birth. So the mothers were very upset, and when they were asked were they exposed to acetaminophen at the start of their pregnancy, more than 70% of the participants said yes, they have been taking this acetaminophen very frequently. But we had no way to confirm that they were actually exposed to high doses of paracetamol. But the people were desperate. They really wanted to know what has caused an abnormality in their babies. So, and they had this recall bias. Then complex diseases and the risk factors, they can be like difficult to read, difficult to observe, or maybe there is interplay of several things and we cannot find that which of the several risk factors has caused a certain disease. The controls, maybe they can have illnesses which are unrelated to the exposure under study. Then they have same referral patterns as cases, and if acute case, they need acute control. Like if you are doing a study on the people who have acute gastroenteritis, then the controls they should also be in the same event. Like they have taken the food, but they have not developed the disease. So we cannot compare them with the people who have been having like the GID problems for the longer periods of time. So the cases and control they have to come from the same time, same population. If the cases are acute, then the controls they should also be acute. Like we are not going to compare them with someone who is inside like hospital for a longer period of time due to other problems. If we have chronic cases, like you are looking at the diabetic population, then you should be comparing them with the people who are in the same age group. They have same demographic features, but they have not developed any diabetes. Okay, so you would want to match them at the root levels. You should remember that control sample of the population that gives rise to the cases, and the purpose of the control group is to provide information on exposure distribution in the source population. And the controls and the cases, they must be sampled independent of the exposure status. Okay. So we use Wood criteria. Wood criteria means that if a person has developed a disorder, we assume that this person would have been exposed to a certain problem. Then each source of controls, it has advantages and disadvantages. Regarding the controls, they should be appropriate matching with the cases. So general concern when you are selecting controls, you should observe certain things like cases and controls. They may differ in characteristics or exposure other than one of the interest. For example, like the cases are low socioeconomic status versus the controls are high socioeconomic status. And you would want to ensure equal distribution in cases. And matching can address this, like you are going to match the cases with the controls. There should not be many differences. The only difference should be that the cases they will have the disease and the controls they will be free of disease. The process of selecting the controls so that they are similar to the cases in the certain characteristics. For example, let's talk about the demographic features like the age, race, socio-economic status, occupations, etc., educational levels. Okay, so all of these things should be matched. Types of matching can be different, like group matching and the individual matching. So in the group matching, we are selecting controls in such a manner that the proportion of the controls with a certain characteristic is identical to the proportion of the cases with the same characteristic. For example, if 25% of the cases they are unmarried, then 25% of the controls they will also be unmarried. And you have to mention all of these things in your methodology method section of the article. Individual matching, like each case paired with a control that is similar or identical for the variable of concern. And after this matching, we call them a matched pair. For example, the cases they have like 40-year-old Asian women. So the controls should also be 40-year-old Asian women. We cannot bring like Caucasian hair and Asian hair. So you have to match the cases with the controls. So as obvious, there can be challenges in matching. Like the cases and the controls, they can be matching on a few variables and it can be more practical. If you are trying to match the cases with the controls at multiple levels, so the chance of error will also increase. And it is really hard to find a match. If you match on a variable, you cannot analyze it later. So sometimes this is known as the overmatching. So that's why we should only match on variables you are convinced are risk factors for the disease that you are not interested in studying. So match the cases and the controls mostly on a few variables, but you should be matching them in the outcome. That what was the exposure, what was the risk factor. Don't try to match them at multiple levels because it will lead to confusions. So how many controls should be there? So the controls, they can be like, we can say roughly like if you want the data to be robust. So if you have one case, then you should keep three controls for that patient. Okay, so to be sure that the what is the difference between the cases and the controls. It doesn't have to be one to one, but there are different ways of doing it. Okay, so they should be of the same type, and if they are of different types, like the population selected from the hospital and the neighborhood controls, or controls with different diseases, so that can be difficult. Okay, so we have to match them and they should be of the same type. Then we need to measure the exposure, can stem and it can study multiple exposures or varying amounts of exposure. Exposure data is dependent on source availability, accuracy, logistics, as well as cost. So self-reported, we can also measure exposure via self-reported, which is by the study participants, then through surveys, questionnaires, which is very common, then in person or by contacting them on phone or through the computer. Like we can ask them to fill up some forms. Then proxy reporting by spouses or parents. Use of medical or other electronic health records. And we can also use the biomarkers. So you can save money here, and these can lead to bias as well. If we are giving them money, maybe they will try to produce the results which the researcher is observing. Recall bias is the biggest when the exposure data is collected. There can be interviewers bias as well. And then incomplete records, which will cause misclassification. So misclassification, it is also going to create a bias. So if you have case control studies, how do we analyze the data? This is an observational study, but still you have to measure the effect, that how much is are the odds that a person is going to develop a certain disease after a certain exposure. Then on the basis of probability, we also need to assess them both. Mostly in the case control studies, we are using odds ratio. What is odds ratio? This is the probability of something occurring divided by the probability of something not occurring. So odds ratio is also a measure of association for a case control study, and it quantifies the relationship between an exposure, such as eating food or attending an event, a party where somebody ate something, and a disease in a case control study. The probability, this is the, it tells you about the chance of something happening out of total possible events, like how many subjects were there. Okay, maybe they were exposed to something, so what is the chance that they are going to develop the disease? So we are calculating the odds and we are calculating the possibility. Here you can see that we have got like five dices. One is somehow black and the other four are red. So in the odds, it is, like I said before, probability of something occurring versus probability of something not occurring. Probability is the chance of something happening. So what is the, like if you have like these five dices, then the question is, what is the probability of rolling a black dice out of a like all of these dices. So the probability would be 1 in 5. 1 in 5, which means about 20%. So what is the so now we look at this thing. What is the odds of rolling a black dice out of a hat? So the odds ratio will be 1 in 4, like that. Okay. So it will become to like 25% because we said probability of having an exposure divided by the probability of having not having this event. So it will become 1 because we are talking about the probability of having a black dice. So 1 divided by 4, we are going to get 25% or 1 by 4. That will be the odds. And if you are talking about the probability like black dice, so the probability of having black dice 1 by the total population, like the how many these dices we have 5. So that's why in the probability we divided 1 by 5 and the chance was 20%. And if you look at the definition of the odds, probability of something occurring divided by the probability of the something not occurring. So that's why we did it like 1 divided by 1 black divided by 4 red dice. So the answer would be 25%. So when you are planning to do a case control study, what considerations you should keep in mind? You should clearly define what a case is. For this, you will have to define the condition and you would want to describe the time limit also, in which duration this thing has happened. Specific case definition to avoid misclassification bias. Controls, they must be comparable to the cases and they should represent study population. Controls, they represent the non-diseased individuals within population. And the limitations, the potential for bias lies in selection of cases and the controls. Here I will give you one example. Like you want to see what is the chance of developing lung cancer in the smokers. And as a control, you are taking the people who are non-smokers. So these groups, they don't match in their characteristics. So you will have to reselect your cases or you will have to select your controls because we are talking about the harmful effects of smoking. So you cannot compare them to the people who are already healthy and they're non-smokers. So their chances of developing the cancers are very remote. All right. So what are the benefits of doing case control studies? Would anyone want to comment on it? Why we do the case control studies? Okay. They are efficient, like let they improve our efficiency. Why? Because we are taking data from the cases and then we are going to trace like exposures, so less time consumption and less money to do the studies, this type of study. These are excellent for rare diseases, excellent for diseases with long induction and latent variants, and they can evaluate multiple exposures in relation to a disease. They are excellent for studying disease etiology when using incident cases. Excellent to use when population is dynamic. The population is changing very quickly. People are becoming sick, and then certain they are improving their health as well. So there are some limitations of case control studies. Like these are the data maybe not like very helpful. Okay, so they are unsuitable for the rare exposures. Now they are excellent for the rare disease, but they are unsuitable with rare exposures. Then recall bias with exposure data and difficult to infer temporal association between the exposure and disease. Then picking controls, it can be challenging. So if we talk about the variants of the case control studies, the case control studies, they can be of different types. Like we can discriminate, we can say that on the basis of time, when we are doing this study, these can be retrospective or these can be prospective. So the case control studies, most of the students, they tell us that these type of studies are retrospective, but remember, They can be retrospective or they can be prospective. So then again, these can be like nested case control studies where you are observing the cases, but they are embedded or nested in a cohort of people like that. Okay, so it can be difficult sometimes, but you don't have to do it like that. Okay, so mostly you are talking about the simple case control study, especially if you are trying to get your first article published, then this can be an ideal study designed for you. Then the case and the crossover studies, like where the cases they will become their own control, and the controls they become the cases. Okay, so that's why we observe them as cases and controls for a certain period of time, and then after a certain period of time, what happens? The cases they become the controls, and the controls they become the cases. So if you are a beginner, then you don't have to go into this detail. Just think about the case control study. In our next class, we will like to discuss the cohort studies because they are also important for you. So we'll talk about it. Make it a point to join the class. I know that most of you people are very much interested in getting your first article published as quickly as possible. We can do that, but the point is that you should understand the basics and then you should move forward, because in the middle of the process, I would not want you to go back and see that what are the strengths of the study, what are the cases, what are the controls, for example, in this case like that. Okay, so in case control study, participants are selected for the study based on their outcome status. And some participants, they have the outcome of interest, which is and they are referred to as the cases. And the other participants in the study, they will be free of the disease. They will not have the outcome of interest, and they are referred to as the controls. And then, as an investigator, you are expected to assess the exposure in both of these groups. Like, you are going to observe the cases and the controls, that what is the difference between the two groups like that. Okay, so if I ask you that the case control studies, they can be qualitative or quantitative, so these are going to be quantitative in nature like that. Okay, and you can do the, so how you can assess the people, the most common way would be that we are distributing them surveys like that. Okay, so that's all you need to know about case control studies. These are very simple, they are not hard, they are going to save a lot of your time. So, this is a good study design for you. So, again, case control studies are observation studies in which two existing groups differing in the outcome, they are identified and compared to the basis of some supposed causal attributes. Like the cases and the controls, they are studied. The only difference between the groups would be the outcome. And why they are good? Because they require fewer resources, but they provide less evidence for the causal interference than the randomized controlled trials. How do we assess it? We assess it with the help of the odds ratio. So this is an inferior measure of strength of association between the exposure and the outcome, and it's not as robust as the relative risk. So this is all you need to know about the case control studies. I hope this information was helpful. If you have any questions, don't hesitate, and you can post in the group or you can reach out to me and I would like to explain everything to you.